Okay, welcome everyone. Welcome to our next session of the morning. I think it looks like more and more people are entering, so we'll be admitting people in as we can go. So I think we should get started. Welcome to everyone, and thank you for joining our technical guidance update session. Firstly, I want to make sure everyone knows that we have translation options for this session available. So please click on the globe icon at the bottom of your screen and select the language that you will need. We have translation in French and in Portuguese. If you're joining from your phone, it might be difficult to mute your original audio, so we recommend that you join from a computer. If you have any difficulties with translation, please put a note in the chat box and we'll triage as best we can. My name is Lindsay Bonanno and I'm the moderator for this session. I'm a health science specialist with the Capacity Building and Partnerships branch in the Office of HIV/AIDS with USAID Washington, which means I spend quite a bit of time working with USAID's transition to local partners. I'm really excited to be moderating this session. In all of our preparation for this year's local partner meeting, we heard the desire to hear up to the minute, late-breaking updates to our technical programs loud and clear. This session will cover updates along the clinical cascade. We will focus on HIV testing, care, treatment, and viral load suppression for adults, children, and youth, and also key populations programming. Our speakers today will share as up-to-date information as they can, but we wanted to also mention that the Country Operational Plan COP22 guidance will be released for public comment on or about November 8th, so in just a few days. This is the best time to review, to get an insight into future priorities, but also to offer comments, suggestions, and ask questions on the guidance. The Office of the Global AIDS Coordinator at the State Department reads and reviews every comment, I promise. I was on the team to review it a few years ago. They get hundreds and they review them. Our agenda for this session includes hearing from our technical experts for about 10 minutes each. And then we're going to open the floor up for questions. Please include any questions in the chat box. And after each of our speakers goes, they can go into the chat box and also answer questions in real time. So I want to give a big thank you to our speakers today. We're all with the Office of HIV/AIDS with USAID in Washington. Vincent Wong is the Chief of the Behavioral and Structural Interventions branch. Thomas Minier is the Chief of the Adult Care and Treatment branch. Nicole Bono is a Senior HIV Treatment Advisor in the Pediatric and Maternal Clinical branch. Tashina Okebe is a Senior HIV Treatment Advisor in the Pediatric and Maternal Clinical branch. And Patrick Hazelton is a Senior Key Populations Technical Advisor in the Key Populations and Human Rights branch. Big welcome to our speakers. Big welcome to all of you, our participants. I will pass it over to Vincent to kick us off. Over to you, Vincent.
Great, thanks, Lindsay. So again, my name is Vincent Wong. I'm going to start my timer here to keep me honest. Got about 20 slides and 10 minutes. So we're going to be talking about the first 90 and HTS developments. Down on the bottom right here, we've got this sort of classic client-centric picture about how we're reaching folks with all of our services. And I just like that to keep that in there as a reminder of how we're programming. Okay, next slide, please. All right, so speaking of that, this is the latest from UNAIDS, reaching global AIDS goals. What got us here won't get us there, and how are we reaching these new infections and the undiagnosed? UNAIDS has a really nice visual now on this, looking at undiagnosed new infections and diagnosed but not on treatment. And those are really kind of our target populations. This is sub-Saharan African data here, and you see the progress and the gap. Next slide. So these have been our standard priority goals for really the past 3 or 4 years now. We've shown the slide every COP season. Right now, we're looking at COP21 and we're looking at achieving our targets above 90%, achieving 100% coverage offer of index testing. That should be index testing to positive ratios. The one goal that's been kind of taken out now is achieving 1.5 partners per index client. Now there's no minimum there, but we want to make sure that the offer is there. And that we're getting really good disaggregations in our self-testing to give us a sense of how we're doing, achieving 95% linkage of all newly diagnosed and making sure we've got good infant coverage of testing at 80% by 2 months. And that was since COP. And if folks can mute the line, or maybe I switched over into Portuguese. And next slide, please. Okay, so just some points for a COP22 guidance that you want to stay attuned to. These may change, but for the moment, there are some shifts. We're taking out the 5 and 10% PITC benchmarks, and there's really going to be more of a focus on local data, local positivities, local gaps in diagnostic rates, treatment-adjusted prevalence, and other areas that are going to feed into your PITC positivities. We're looking at removing the benchmarks around percent of positives for index, focusing again on 100% offer, focusing on pediatric index, and considerations around new blood-based options for HIV self-testing and their use in different areas and different programs, including PrEP. Okay, next slide. So here's our Cascade for all of USAID's programming in Q3. Point here is we reached 232,000 positives and linked most of them to care. We're at 91%. We'd like to see that at 95, but overall, we've got a good cascade. Positivities at 4% for all testing, which is about what we've seen in the past. Next slide. And when we break that down by country, we kind of see that our successes. We're at 90% for testing, 72% for pause, and self-testing's achieved 76%. So we're doing really well. There are a few countries that are quote unquote underperforming with low diagnosis or testing too much to not quite meet their treatment targets. We understand that COVID is affecting a lot of this. It's this is a systemic pandemic that we're dealing with, and it's affecting all of our programming. Nevertheless, we've made good achievements on testing writ large. Okay, next slide. How are local partners doing? So this gives us a bit of a comparison. Top bar is local partners, very bottom is international partners who are doing a bit better, but the local partners here at 79% delivery of HIV self-testing. You're under testing a little bit on the positive side relative to your testing side. That means your yield assumptions weren't quite panning out as expected, but all in all, good numbers. Next slide, please. And we know across the testing modalities that PITC, index testing, and to a lesser degree, community mobile and ANC testing with lower positivities tend to be the drivers of diagnosis. This is where we're seeing the bulk of folks being diagnosed in our programs. Next slide. And the associated positivities. When we consider linkage, again, that 91% broken down by countries, we're doing okay. The line gives us our linkage line. That's 1 positive to 1 treatment new. We know there's more positives than treatment new. So if you're above that line, that's fine too. But overall, you see some of the positivities here, and we're striving for that 95% benchmark. Next slide. Reaching men. We had a last session with a lot of strategies unpacked in Haiti around reaching men. This has been our framework that we've leveraged MenStar for, identifying the areas where we've got low knowledge of serostatus in men, low ART uptake, identifying the barriers that need to be addressed to delivering services, and then thinking through critically and creatively around how those services are tailored, tweaked, and delivered to engage men in acceptable services. I won't go through the bullet points here, but it is an area of focus for PEPFAR, and it's an area of focus for USAID with some really good successes. Next slide. COVID, this is a slide from last October, but much hasn't changed. We've seen the leveraging of self-testing. We've seen the use of PPE and support of safety in our staff to deliver testing, to adapt the programs to meet the targets that we've seen previously. We've done, by all measures, pretty well on this. And I think some of these interventions speak to those results. Next slide. Self-testing, here's our package framework. Again, focus here is scaling. The focus here is self-testing as an amplifier of our programming. And there's diversity of product choice. So self-testing is a tool, and we've got to think about how we're using that tool to achieve the programmatic goals that we're setting for ourselves, right? It's not an intervention per se. There's a lot of decision-making here. And so far, we're doing quite well. Next slide. We'll show that. So we've doubled our kit distribution from Q3 to Q3. A lot of this has to do with COVID, but we are expanding use and leveraging it more country to country. Next slide. Here's our country level look where we're seeing the expansion, a lot in South Africa, Malawi, Zimbabwe, some with reductions, but it is for those reducing a point to say, okay, in COP22, are we where we need to be with self-testing, and could we be doing more with this new tool? Next slide. Here's our results to targets. Again, some differential with countries, some with large targets and lower performance. So that might be recalibrated in COP22, but all in all, doing quite well in delivery expansion. Next slide. And this is our percent of self-testing in relation to all testing. So you can see the countries where we're having lower investment, where we might want to see some expansion. And then we see some countries with high investment, which might be just at the right point for amount of delivery that they're doing. So it's a good reference point. It's not a standard view, but it's a nice comparator. Next slide, please. And here just showing that we do have implementing partners. This data is a bit old, but it does show us a cascade. I know I've seen recent data from implementing partners that shows a cascade of a subset of recipients of self-testing leading to downstream ART uptake, which is in fact our main goal, although we might see some broader prevention applications in the coming COP year. Next slide. Here's the test kits, the price points. We've got a number that are pre-qualified, 4 of them. In fact, that first one on the top is a blood-based assay coming in at just under $2. So just be aware that there are multiple options here. It's not only OraQuick, which might be preferred in many instances, but the blood-based test will give you greater sensitivity earlier in disease stage. So there are probably applications for that, for instance, in PrEP. And just to note that we've got a bit more choice here than we did a few years ago. Next slide. Thinking about positivity, highest that we've seen in PITC, there's a lot of focus on this, was 6%. Here's our shifts. We've really improved year to year. The blues are improvements in PITC positivity. A lot of this has been done with risk screening. There are risks and benefits to that. We'll talk about those in the next slide. You can move there. Now, this is an example from Malawi and risk screening. So I won't go into detail about this, but the gray bar is a baseline screening, and the yellow bar is a full screening. And what we see here down the chain, moving down the y-axis, is just a loss in diagnoses. So we've got to be careful in balancing the risk screening with reaching those who need to be testing and not screening out folks who don't. And you can take a look at that paper that has a lot more detail on this if you're interested. Next slide. This is a WHO slide stating exactly that case. They've done a large systematic review, and they're concerned about folks being missed because people are being screened out too stringently, but are interested in seeing ways that we can screen in those at risk and balance the risks and benefits of approaching programming with risk screening tools. Next slide. Here's our index cascade. Again, we had seen some real successes here. We're very interested in making sure we extend index testing offers not only to test positive tests, but also virally unsuppressed. That's what we see here. So we see an offer rate that's much higher than our test pause volume in Q3. And this cascade is looking really strong. Offers over 100%, acceptance rates that are acceptable, context delivered, and positivity and known positives elucidated here. So positivity rates at 24%. I know there's a lot of variation there, but we're doing, this cascade tells us that we are doing quite well at our delivery of index testing. Over, next slide, all right. But we want to make sure that we are providing safe and ethical services. These are all like minimum standards for what we're delivering, right? We want to be sure that there's no coercion. We are adjusting our targets appropriately. And so these bullet points are really important to attend to relative to that cascade on the previous slide. Next slide, please. Okay, this is our most important slide of the day. These are your people. So this slide deck was not me. I'm just presenting it, but all of these folks are the folks working on testing programs in the countries specified here. Reach out to them if you've got issues, questions, problems. You can reach out to me as well. But here are their names, here are their countries, and here are the emails. And you can reach the entirety of this very strong team at the HTS team at usaid.gov. So thank you. I'm a few seconds over, but I'm turning it back to, I think, Lindsay.
Great. Thank you very much, Vincent. I think you do also have a few extra slides that maybe, Courtney, we can just tap through with additional resources. Whoops. Great. And we'll move right on over. Again, if you have any questions for Vincent, please put them in the chat. But we'll move over to Tom to cover our start our care and treatment section. Over to you, Tom.
Hi, everyone. Good morning and good afternoon. And actually, this section is going to be a little bit less compressed, I think, because by and large, with treatment services, there isn't going to be that much of a difference in the coming year for COP guidance from what we've been doing in previous years. That said, there are a couple of areas where there's, I think, some added emphasis, and it might be worth at least discussing some areas and ways that PEPFAR is approaching treatment and clinical services slightly differently when we're evaluating performance and how we're doing at reaching many of the demographics and recipients of care we wish to reach. So with that having been said, I'm going to sort of talk briefly about 5 main areas here. The first being continuity of treatment, our ART regimen optimization, and then DSD and MMD, and then highlight a couple of areas. In fact, there's probably 3 here that I think are going to get a little bit of extra emphasis in the guidance. Next slide. So the first is continuity of treatment, which is also, it's sort of a new term for retention. For those of you in the partner space, I know that everyone probably at the agency level at USAID, CDC, DOD has probably heard a lot about continuity of treatment and our use of the TXML indicators. In previous cycles, one of the things that was analyzed was a retention proxy. And I'm bringing this up just to highlight for those of you that are doing service delivery and working at the facilities, it's important to make sure that we have this TXML disaggregate well done, essentially. If you go to the next slide, I've highlighted a couple of the dashboards that are being produced. We no longer have been looking at this retention proxy, although at times it can be helpful to analyze this, as sometimes silent transfers can be captured in a retention proxy at certain levels that are not captured very well with the TXML. But by and large, the metric that everyone is looking at is the interruptions in treatment, IIT. This gets disaggregated by how long people have been on treatment, whether or not someone has newly initiated ART versus been on ART for several years. It gets disaggregated by district. It gets disaggregated by age and gender categories. Next slide is an example of a USAID dashboard that we're looking at to try to target our interventions to facilities where we are having problems with retention. If you look in this middle graph here, we have all of the facilities mapped out by size and the rates of interruption in treatment. And we're looking at sort of the age and gender disaggregations as well up in the top right. And we tend to find that there's a lot of older folks that get lost and cycle in and out of care. So we need to try to create services that really reach them and meet their needs. All this is to say, I just wanted to mention this because it's going to be really important for those of you that are working to try to help improve retention and continuity of treatment, or working at facilities to make sure that this metric is well attended to and that the data quality is good, because this tends to be what people get graded for in the treatment space. Next slide. So this segues a little bit into the differentiated service delivery component, because retention is really a multifaceted approach. One of the things that we need to do is set up those systems at each clinic that really allows us for more of an individualized support to our recipients of care to facilitate that lifelong engagement. This is really a paradigm shift from what we used to do in PEPFAR, which was very much a public health approach, simplified model, roll it out to everyone. To keep people, now that we're reaching these high levels of ART coverage, it's really about retaining the people who've already been diagnosed and have been engaged in care at some point. We need to focus on building services that meet their needs. And there's, that may be a very simplified model like facility-based MMD for the majority of folks, but for the rest, they may need psychosocial support, mental health services, the benefits that come with being in, say, an adherence group or an adherence club, et cetera. And there's a lot of systems development that goes into undergirding this capacity to make sure that we know what our patients need and that we're providing it. Next slide. So the only metric we have at this point to describe our DSD and truly how patient-centered, which is the word that gets used a lot in the guidance, is really our MMD disaggregate of TX cur. And that doesn't really tell us how well our patient-centered services are truly patient-centered. So USAID in coming cycles is going to be asking a lot of our partners to actually begin to survey patient preference, build this into our standard operating procedures, where we ask our clients how they want to get their drugs, in what quantities. Some people want MMD, some people may not. Do they want to pick it up at the facility? Are private sector pharmacy points a more convenient location? Are adherence clubs something that you might need? So we'd like to survey our patients periodically on what types of services they need, be able to categorize them in some way, and then monitor the viral load suppression and the continuity of treatment for those different models. So there are going to be some custom indicators coming down the pike. We haven't finalized them yet, but they'll hopefully be simple enough to try to track this and really find out if we are providing truly patient-centered care. Next slide. I'll speak very briefly to the optimization of ART regimens. I think many countries have done a fantastic job transitioning to TLD for adults. A big focus of emphasis this coming year, especially as pediatric dolutegravir supplies are hitting a lot of countries, will be to focus on ensuring that all kids that are eligible to take dolutegravir are able to. And I can give a little bit of a teaser in that we are trying to work with industry right now to improve the supply of a generic darunavir-ritonavir combination to replace really any need for both lopinavir and atazanavir. I suspect very few local partners are doing procurement, but know that you'll need to sort of help where those transitions are occurring to help sensitize patients to why, the rationale, and the real benefits to moving to these new medications. Next slide. This is where I think many of our local partners will have a distinct advantage, because you're based in the cultural and social context in which our recipients of care live. Treatment literacy and really understanding the disease course, how ART works, is absolutely critical to ensuring that folks reduce, that they remain engaged in care, and it reduces levels of community-based stigma for HIV. So really amplifying that U equals U message and ensuring that folks know that they can live long, normal, happy, healthy lives with a simple 1 pill a day. that this suppresses the virus and that it allows them to be able to move on from that illness mentality, I think is going to be particularly important. And this is going to require interventions at both the facility and the community. Next slide goes into advanced disease. This is going to receive a little bit more of an emphasis in the upcoming COP guidance, and the rationale is quite simple. In previous years, PEPFAR had purposefully moved away from CD4 testing, which was something we used to do quite routinely for all of our clients. But we were doing it largely as a monitoring tool to try to figure out whether or not essentially someone was doing well on therapy. Viral load is a much better test for that. That said, still a large number of patients, perhaps around 15%, are, when they test positive, they're showing up with a CD4 count that is less than 200. And that makes our recipients of care vulnerable to a variety of different diseases and increases rates of mortality. People do present late, and that is a hard thing to overcome. So that said, we'd really like to emphasize for those new patients coming in, as well as patients who've returned to care after an extended period, say a year away from ART, to receive a CD4 test to see whether or not they can get that package of services that helps prevent mortality in those with advanced disease. Immediate ART is going to happen regardless, but certainly cotrimoxazole, TB screening and treatment, that's half of our advanced disease mortality right there. Crypto screening and treatment, and where appropriate, nutritional assessment and supplementation for severe acute malnutrition. There is a Visitech test, which is a true point of care test. It's like a rapid test for CD4. It's a little bit more complicated to actually do, but I won't get into that here. The point is, it can be done as a finger stick and allow within about 20-25 minutes a determination if a person is below CD4 of 200 or above. Doesn't give you a number, but it does at least tell you who's at risk for advanced disease. So where CD4 testing isn't readily available, we'll have this to procure. Next slide. And the last piece, I think this is my last slide here, is just that there is an added emphasis on integrating point of care instruments where possible, and some of this will involve multiplexing them as well for viral load, EID especially, and TB diagnosis. And I think we could also add COVID diagnosis with certain platforms onto that as well. With many of our countries, it's inefficient to have point of care machines everywhere, even though it would be nice. It's a hard supply chain to maintain, and the machines and reagents cost a little bit more than our standalone traditional platforms at our larger labs. So as a result, we are encouraging all countries to do diagnostic network optimizations to figure out those sweet spots where it is taking a long time for results to get back, and where we have point of care machines already, where we can essentially leverage them to optimize their function, make sure that they're being used pretty much all the time, and prioritizing, of course, EID and TB diagnosis first, but then using excess capacity to do viral loads. So you'll see a lot of those. For those of you, the partners that are working again in facilities, you will see this move towards point of care machines. It's something that civil society is certainly very high on. I think we like it as well. It's just a question of being able to afford it all and nest it within a system that allows us to reach everyone. Next slide, I think, is my last one, and I can turn it over. I mean, in the end, treatment services really aren't any different than in the past. It boils down to understanding our recipients of care and designing essentially efficient and effective services that empowers them and meets their needs. So there's a few areas of new emphasis, but otherwise it's still the same thing. Thanks, Lindsay. Back to you.
Great. Thank you so much, Tom. There are a few comments or a few questions for you in the chat box on advanced disease, and one on CD4, which you answered while you were speaking. So I don't know if you wanted to add anything else on. We'll move it on over to our pediatric and adolescent treatment section with Nicole Bono and Tashina Akebi. Over to you, Nicole.
Great. Thanks so much, Lindsay. So now we'll take a look at our pediatric, adolescent, and to some extent youth populations, taking a look at some of the priorities and resources we have for the coming year. Just to take a look, first of all, at the broader picture, the UNAIDS estimates for 2020 that were shared in mid-2021, they are and they were disappointing to see that we have made progress over time, and we've made significant progress over time, not to take away from that, but we have really had a stable and progress since 2015. There were 310,000 infections in 2020, and those were split almost evenly between 0 to 9 and 10 to 19-year-olds. Next slide, please. When we take a country by country look at the ART coverage for adults and children, on this graph, you'll see children represented by the bars in blue and adults in orange. Most countries have a significantly smaller proportion of children living with HIV on treatment, and particularly the countries to the left. Some countries have a very large difference, and just to highlight a few of the countries that have around 90% of adults on ART, but at or less than 70% of children include Burundi, Nigeria, Uganda, and Zimbabwe. So we really hope that our local partners can continue to help us close these gaps. Next slide. So where are we as USAID and specifically as local partners? You saw the clinical cascade earlier. This is specifically looking at pediatric populations for under 15-year-olds as of FY21 Q3. On the left, under the first 95, we have case finding. It's really important to identify children and adolescents living with HIV and initiate them on treatment. For the second 95, we see similar levels of proxy linkage, which is strong at 106%, and high continuity of treatment at 99%, so comparable to our international partners. What's really exciting for the under 15-year-olds in Q3 was that there was a really good treatment growth, 15%, so a positive net new. That's typically where we see the interruptions in treatment that Tom spoke about earlier and treatment loss. So when compared to USAID implementing partners overall, there was a 3.5% loss. So we want to see quarter on quarter treatment net new being positive. So local implementing partners are really doing well in this area, and we just want to say keep up that great work. For the third 95, we see that local partners account for 18% of all children living with HIV, over 120,000. That's TX-CUR, and we do have room for improvement, as noted, for viral load coverage and particularly viral load suppression. We'll come back to that next slide. Moving to adolescents. So for the adolescents, that's 10 to 19-year-olds. Local partners account for about 20% of all adolescents, with a TX-CUR of almost 150,000. Proxy linkage is lower for adolescents at 85% compared to the under 15-year-olds. And it's slightly higher than for the overall program at 82%. So local partners, we're doing better in this area, but still room for improvement. So while linkage is low, the TX net new was also positive this quarter, so that's encouraging. Viral load coverage and viral load suppression for adolescents is slightly higher than for children, but we know that this is also an area for improvement. Next slide. I think that Vincent spoke very clearly about the need for an optimal mix of case finding modalities. So we're talking about the first 95. This slide shows the three main approaches to finding new cases of HIV among children and adolescents. The first approach in purple to the left is index testing, which focuses on testing the biological children of people living with HIV. We call this exposure-based approach because we find these children through asking women living with HIV to name their biological children who may have been exposed to HIV during pregnancy, childbirth, or breastfeeding. The second approach is provider-initiated testing, shown in pink, in outpatient clinics, well child clinics, and OVC programs. We often use a risk screening tool, as Vincent spoke about, with questions about the child's testing history, parental status, and overall health to identify which children are at risk and need to be tested. Finally, in blue, the universal testing of all sick children who are hospitalized in inpatient wards attending TB clinic, malnutrition, or STI clinics.
So, Nana,
This
all
means
the
we,
best.
sorry, someone who's off mute. Thanks. We test all children in those services. We need to balance these three different modalities. The three things articulated on the right in the triangle are looking at the absolute number of new diagnoses, the NNT, which is number needed to test, and the cost per positive individual diagnosed. While effective and efficient testing is important for all populations, for children, early case identification of children and adolescents is a priority to reduce morbidity and mortality. Partners should review their testing data for under 15-year-olds and over 15-year-olds. The absolute number of children identified is a priority metric to assess testing strategies for children living with HIV, and missed opportunities should be minimized. There is a new resource at the bottom of the slide, which I've put there. It's on the PEPFAR Solutions website. It's for index testing of biological children and adolescents, a collaboration between clinical and OVC partners. Next slide, please. And as Tom mentioned in his presentation, pediatric DTG, we're really excited about this as a game changer for children under 20 kilos. It's a dispersible tablet for children weighing 3 to 20 kilos. In terms of the advantages compared to lopinavir ritonavir, it's once daily, it's more easily administered, it has a pleasant taste, it can be easily used for MMD, it's less expensive, and will result in overall program cost savings. So we've seen a number of countries moving towards rapidly towards this transition. There's 18 countries that have received it as of September, and 14 that are reporting or that reported plans to offer it as of also as of September. We do recommend that all countries rapidly transition children under 20 kgs to pediatric dolutegravir, and we do expect to see improvements in viral load suppression with this new treatment. I provided another resource at the bottom of the slide for some different materials for healthcare workers, caregivers, communities, and the media to spread the word about the benefits of the new pediatric DTG. Next slide. When we look at MMD, multi-month dispensing takes a client-centered approach and has the promise of improving continuity of treatment and as well as viral load suppression and reducing the volume of patients at facilities, which is particularly has been useful during COVID. We've made progress in accelerating MMD for children and adolescents, as you can see from the graph on the left. There are more pediatric clients on 3+ MMD than not, as shown in the blue bars, but there has been a bit of a plateau since FY20 Q3. 6 MMD has increased slightly to 10%. I've also included on the slide several resources developed by USAID partners to support MMD for children, adolescents, aimed at healthcare workers, community caseworkers, children, and adolescents. Next slide. Viral load coverage remains less than 85% for most countries and for both children and adolescents. So, what are the reasons for this in your country? Is it that children are not being identified as needing a viral load during their clinical visits? Is phlebotomy a challenge? And is DBS a solution? Or there are broader issues like commodities, sample transportation, or laboratory issues? For younger children, we know that pediatric blood draw commodities can help, and DBS is also useful as a sample type. But it's also important to ensure we don't miss a viral load for children and adolescents when offering them MMD or differentiated service delivery models in the community, including team clubs and other DSD models that are targeting children or adolescents. Next slide. We also want to highlight the collaboration between the clinical and OVC programs. We've seen that this can really make a difference across the cascade for children and adolescents. We know that the comprehensive model is only one of the OVC models, and that children and adolescents and their caregivers receive individualized support across the cascade, as summarized in this graphic. The comprehensive model addresses the unique needs of each household to overcome barriers or challenges and aims to ensure that everyone in the family unit is healthy, safe, stable, and schooled. The health facility is a fundamental entry point for OVC assessment enrollment. Therefore, the collaboration between OVC and PEDS clinical programs is essential to improve pediatric HIV outcomes. So we've listed some of the OVC priority subpopulations here. And we do have a number of panel presentations tomorrow where you can learn more about the collaboration between OVC and clinical. Let me pass it over to my colleague who will talk about the youth package of services. Over to you, Tashina.
Thank you, Nicole. And hi again, everyone. My name is Tashina Okibi, as mentioned before, and I co-lead our Adolescent Care and Treatment technical unit within OHA. So given that adolescents and young adults have poor HIV outcomes across the clinical cascade, we've been thinking really deeply about how to better target services for these populations who we know have unique needs. An enhanced focus on adolescents and youth is vital to maximize the impact of the agency's overall response to combat the HIV epidemic. And to that end, and still in draft, is an approach that we've developed here at OHA, outlining a comprehensive core treatment service package for adolescents and young adults who are living with HIV. This package of services was developed to support healthy, resilient, empowered, and undetectable adolescents and young adults. It outlines multiple evidence-based interventions that address key challenges that are faced by this population. So just to draw your attention to the graphic, the package is underpinned by 4 core guiding principles that you'll see to your left: positive youth development, or PYD, youth engagement, trauma-informed care, and ages and stages. The PYD approach is the underlying principle of USAID's Youth and Development Policy and aims to build the competencies, skills, and abilities of youth that they need to grow and flourish throughout life. Through a PYD lens, young people are not regarded as problems to be solved. Rather, they are seen as assets, allies, and agents of change who have much to contribute in solving the problems that affect them the most. The principle of meaningful youth engagement is fundamental, underscoring the idea of nothing for us without us. Programs should also take a trauma-informed approach to care, acknowledging that healthcare organizations and care teams need to have a complete picture of a patient's life situation, both past and present, in order to provide effective healthcare services with a healing orientation. And then finally, it's really critical to take into consideration the socio-developmental and life stage of adolescents and young adults when providing health services. So quickly, in the second column, you'll see the 4 package categories: clinical services, psychosocial support services, clinic environment, and then health communication and social behavior change that all care and treatment programs should include. The third column lists the package components and interventions for each category. And finally, the fourth column lists interventions or services that would be included in a secondary package for AY-LHIV, depending on their individual unique needs. This could include the integration of other health services, such as family planning and mental health, as well as integration with other sector programming, including social protection services and educational support. So we look forward to hearing any feedback that you may have about this draft package as we continue the finalization process. Thanks so much.
Thank you very much, Nicole and Tashina. We'll now move over to Patrick to cover our key populations programming. Over to you, Patrick.
Great, thanks so much, Lindsay. And thanks for this opportunity to share on behalf of the Key Populations team. I'm Patrick Hazelton, Senior Key Populations Advisor at USAID OHA. For today's presentation, I just wanted to take you through a few elements. So first off, and I apologize for those of you who already have extensive background in key populations programming, but I did think it important to include just some basic definitions of key populations and why they're important in the HIV response. But I also want to move into looking at some of the solutions we're seeing within PEPFAR for working on KP, and also similar to other panelists, just looking forward to COP-ROP 21 and into COP-ROP 22 planning, just giving you a little sense of on the policy and programming landscape, what we're looking for in terms of the next steps for KP. So on this slide, again, just briefly defining KP. This is the 2016 WHO guidance. We can see men who have sex with men, female sex workers, people who inject drugs, transgender people, and prisoners and people in closed settings are all included in the definitions of key populations. Not included in these definitions, but of great importance, are also the sexual partners of KP, and together with KP make up a majority of global infections worldwide. Next slide, please. So again, we get year by year more robust data looking at the vulnerability of key populations, the HIV risk vulnerability. Here we can see anywhere between 26 and 35 times greater risk for key populations relative to the general population. So pretty striking figures, again, really underscoring the importance of KP within the global HIV response pretty much everywhere in the world. Next slide, please. And underscoring again that point, I just want to go through a few highlights here, just even most recently. So from 2020, and we have even more up-to-date data from 2021, but just to emphasize the point that when we talk about the global HIV epidemic, we still should keep in mind how important KP are. Majority of infections, 65% of new infections estimated to be occurred among KP and their partners, and this is the most recent 2021 global UNAIDS report. However, as many of you know who work on KP issues, KP programming is significantly underfunded. Only 2% of global HIV/AIDS funding is spent on key populations and only 7% on prevention. We've seen a trend for years where KP targets within PEPFAR are going up, but budgets are going down. At the same time, a few points of note on the policy level that do have the opportunity to potentially move the needle include that differentiated service delivery are increasingly emphasized in forthcoming WHO KP guidance, as well as recently published WHO ART guidance. Also, under the new administration, we are seeing more of an emphasis on advancing the rights of LGBTQI plus people. So the White House memo from this past February encourages an expansion of efforts in support of LGBTQI plus people within foreign assistance programs. And this also offers the opportunity to have PEPFAR strike an approach where there's not necessarily a requirement for integration into government services where criminalization and discrimination remain predominant. So again, a number of opportunities this offers, both within USAID, but across agencies with the State Department. And we're working on seeing how this plays out within PEPFAR for additional funding opportunities, especially for key populations programs that work with MSM and transgender people. Next slide, please. So this again these data have been.
Can you hear me, Mamba?
Please mute if you can. Thank you. So these are updated for 2021, but the trend lines are still the same. This is 2020 data here for all regions of the world. KP and their sexual partners making up a majority of infections. Even within Eastern and Southern Africa, where we have the largest volume of HIV infections, we still see 28% of new HIV infections are among KP and their sexual partners, and MSM making up a particularly important group in a number of regions, including the Caribbean, Latin America, and Asia. And again, as I mentioned before, sexual partners increasingly being identified as really important. And when we think about key populations programming, we haven't often in previous years thought about sexual partners, clients of sex workers, other partners who may be reached effectively by KP programs, index testing offering opportunity to reach these populations, but also a number of other community and clinical-based services that have proven effective for meeting the broader services of KP and their partners. Next slide, please. And again, for those of you who work on KP programming, none of this should be a surprise. We fully expect this when KP programs are in the field, that there are these key challenges: stigma, discrimination, and violence on a number of levels, posing challenges, KP needs not being addressed by mainstream clinicians, capacity being relatively low or nascent among KP community groups, including among local partners who are working in the field and who are receiving prime awards for the first time, social barriers, including need for tailored psychosocial support and case management, funding challenges for KP groups, as well as data collection challenges, which I'll talk a little bit more a little later. Next slide, please. But again, we want to also highlight some solutions and some really positive developments on the policy front. So this is from forthcoming expected 2022 revision to the WHO Comprehensive Package of Interventions for Key Populations. Just a few things of note to highlight. I mean, this box on the right for service delivery, there are a couple of new points that were not included in the previous WHO package that we're really happy to see there, that KP are considered. Effective KP programming includes components like integration of services, decentralization, task shifting, trying to get away from an over-medicalization of KP services, which is especially important for areas like PrEP and HIV self-testing, community-based approaches, including KP drop-in centers and community clinical sites being very important, and also an increasing integration of STI testing, of PrEP being really emphasized in a way it wasn't in previous guidance, and also a number of these structural interventions, which we can see here in gray, are being emphasized for the first time, addressing stigma and discrimination, and again, structural interventions that maybe were funded under the Key Populations Investment Fund. We have much more robust evidence from the field for programming that works, that includes these elements of human rights and structural interventions. Next slide, please. Also wanted to show you just a little schematic of differentiated service delivery. So again, this being more emphasized in the recent or the forthcoming revision to WHO package of services. And we're seeing this effectively implemented in a number of countries now, and local partners being part of differentiated service delivery in many countries. This is an example from Zimbabwe. And traditionally, key population services have been focused on the community level, so on the left-hand side here. But increasingly, we are seeing clinical programs supported by USAID that also are very trained to work on key populations issues and really focusing on some of these elements like integration of services, task shifting, and making sure that there are clear connections between the community and clinical interface, and also increasingly approving community sites as part of a national public health model. So Zimbabwe, Malawi, a number of countries have been able to implement these opportunities for getting official approval for community sites to be considered within the national public health system. And again, we think we're going to see increasing opportunities within PEPFAR to move the needle, the policy landscape. In some cases, we're still prevented by local policies and regulations, especially where criminalization and discrimination of KP are rampant, but differentiated service delivery and its increasing acceptance as a model of services for KP offers a lot of hope in this area. Next slide, please. I also wanted to highlight going online solutions, especially in the COVID-19 context. We're seeing increasing expansion of going online for KP services. So this is an example from the EPIC central mechanism has deployed an online reservation app that includes components like virtual case management, as you can see here, telecounseling, telefollow-up, referral, and delivery. And it's not a proprietary system. It's a system that also local partners have the opportunity to take up, and that it has the opportunity to seek country ownership. So it's meant to be low cost and to be relatively easy to deploy in a variety of settings. And again, given the COVID-19 context where we're seeing a lot of services being moved online, it's another opportunity to get into new networks, to reach key populations who are more hidden or harder to reach through traditional in-person services. And we're seeing increasingly strong results in this area. Next slide, please. Also wanted to talk briefly just about the challenges and potential solutions within data and data reporting for KP. So again, for those of you who work on KP issues, this has been a long-standing challenge where data is somewhat erratically disaggregated for KP across countries, across programs, and we've done a lot of work to have much more robust data and many more examples of really strong disaggregated data for KP. The fact that stigma and discrimination can affect how KP are reported, lack of political will, the mobility of many KP can make it hard to track. The lack of unique identifiers is also a challenge, and the lack of integration of KP information systems within national health systems are all challenges. But again, we do have some really strong examples from the field of KP information systems being integrated into EMRs. The national the DHIS2 e-tracker system that EPIC has deployed in a number of countries and now local partners are also using is another way to have better electronic tracking of KP and increasingly track into national systems. And having civil society engagement on this is also quite helpful to make sure that there are policy changes, that there's access to commodities, and sensitization of providers so they can more accurately report on KP services. Next slide, please. And just these final two slides, I just wanted to give you just a little taste again of heading into the new COP year and where we're going for COP22. So human rights are anticipated to be reinvigorated throughout our PEPFAR programs. We have a great body of evidence from Key Populations Investment Fund for human rights programming. But also, again, with the new administration, we're seeing human rights being emphasized at the State Department and USAID. And this offering opportunities for structural interventions that were not previously there. Strategic information systems, scale up is quite an important element, and DHIS2 e-tracker system that I just mentioned is one component of this. Viral load coverage increasingly being reported on and being improved upon for key populations, differentiated service delivery scale up, as well as collaboration increasingly with Global Fund, UNAIDS, WHO, and Gates around national KP scale-up in a variety of areas. And final slide. So I just wanted to leave you with a little taste of how you, as local partners, can take action to drive the KP agenda. So again, there's a long, robust involvement of civil society in KP programming and making sure as part of the annual COP processes that KP issues are heard loud and clear. Especially with this renewed emphasis on human rights. Your knowledge of human rights and health is one of our assets, as well as your relationship with KPCSOs and advocates. So be sure to engage with KPCSOs in advance of the COP process. It's mandated as part of the process, and it's a way to have increased attention to KP issues. Be sure to promote any results you have around structural interventions and look for opportunities to expand those. Continue to improve upon data collection, monitoring, and SI capacity for KP programs, and engage with your mission KP POC. And also, here at OHA, we have the opportunity to support you with discussions that are happening with Gates, UNAIDS, Global Fund, other donors. There's a global landscape all around KP issues that we want to make sure you are aware of and connected to. And finally, leveraging existing resources at the national level. There are potential opportunities around public health insurance systems, local government, domestic resources that may be available in a variety of countries. So definitely make sure you are tapped into those. So I believe I'm at time now, so I will pass it back over to Lindsay. Thank you, everyone.
Great. Thank you very much, Patrick, and to all of our presenters. So we have 30 minutes for questions and answers. So how we'll do this is if you want to put a question in the chat box, feel free. I see many have already done so. If you would also like to ask a question audibly, please go down to the bottom of your screen where it says reactions and click on raise hand. And that will be how I see that you want to go off of mute and ask a question. So again, please either put your question in the chat box or raise your hand so we can see who would like to go off of mute and ask a question. We did get a couple of questions for the slides. So I wanted to reiterate what I put in the chat, that all of the slides and presentations from the entire meeting will be going onto our conference platform website after the meeting is completed. So you will all have all of the slides that have just been presented and all of the slides from the plenary and panel presentations as well. So we will, Patrick, it looks like there's a few questions in the chat. If you want to either look through them and answer them in the chat, or we can have you come back on video. But it looks like Tendai has her hand up. Very good, Tendai, to ask a question. So Tendai, please feel free to go off of mute and ask your question.
Thanks, Lindsay. Good afternoon, good morning, good evening, everyone. So my question is really around countries like my country, Zimbabwe, where our programs are almost, if you can call it, maturing in quotes, and towards reaching epidemic control if it has not been reached already. And just a general question to maybe Tom and others on any thoughts around any threshold for treatment net new, or where possibly how we can I will look at an epidemic at that stage in terms of who is coming into the program and who is leaving. When you're looking at our TX car, I think we understand as our TX car was continuously growing and we're seeing rapid changes in the TX car. We're really interested in growing the TX car as much as we can. But at some point, perhaps coming very soon for us, has there been any conversation around for epidemic control countries, how that growth or that expectation will be viewed in light of the fact that naturally, as long as people are on ART for a long time, there will be some, attrition out of that cohort. So I think, any conversation around looking at that in that lens. Thanks, and over, Lindsay.
Thank you, Tendai. So I heard some questions from Tom and then possibly others. So over to you, Tom.
Yeah, it's a really good question, Tendai. And, I certainly wouldn't be able to give you an official answer because PEPFAR to some extent is in a little bit of a holding pattern. They're about to unveil a new strategy for this next phase of PEPFAR. We have a new ambassador who's been named but hasn't been confirmed. So we don't have a sense of how John Nkengasong, if he is confirmed, will want to run PEPFAR and what he will want to emphasize. I think many of us worked with him in the past, and he actually has been very, very collaborative. So I think we're all very optimistic that this will be a slightly less tortuous PEPFAR process in the future. That said, pretty much all of the targets are driven by those spectrum models. And I've got to be very realistic that some models are useful. All models are wrong, but some models are useful. Spectrum certainly falls in that case too. It's not perfect, especially in areas of Southern Africa where there is a lot of mobility and migration, as I know certainly impacts Zimbabwe. So, there's a lot of predicted people who will be in certain areas, but may not actually be there most of the time. And that makes the target setting rather challenging, so to speak. But the shorter answer to that question is yes, as countries are achieving greater rates of epidemic control, and we've certainly seen this in some of the countries, there was always this expectation that you needed to add to TX curve and make sure that net new was growing as fast as possible. But with several countries, even in this last COP cycle, the targets have been a little bit more realistic because we've recognized that it is no longer about finding so many TX new. We expect the TX curve to kind of go up, but probably not by as much as it had been increasing in previous years. So I think, when targets get reached, we would encourage country teams across the interagency space to focus on realistic targets that we think are achievable, knowing that in a country like Zimbabwe, where there's hundreds of there's over 1 million PLHIV on treatment already, it takes a lot of work to keep those folks continuously engaged in care, and that's where a lot of the emphasis will likely be, rather than on trying to get new patients into care. But again, if there are pockets, and that's what the spectrum models suggest, then there'll probably be higher TX new targets in those, geographic regions and areas or with certain populations. So short answer was yes, we expect the TX net news to be decreasing over time as countries get there. But just know that there's some caveats with a new ambassador coming in, and that those models aren't always predictive of reality. They get sort of readjusted every time a new FIA comes out.
Yes, go ahead, Vincent, please.
Great, thanks, Lindsay. I didn't know if others were in queue. So thanks for the question. And second, really all of Tom's comments around the spectrum estimates. and everything that he said. I think moving to the left of the continuum and thinking about the testing picture, because it comes up a lot in our internal discussions. It comes up a lot in discussions with partners around, as we achieve quote unquote epidemic control, and recognizing there are different definitions of that when people say it, but assuming here we mean the 95, 95, 95 targets. How does testing change? How does the testing investment case change as we reach that? Again, similar to Tom, we don't have a defined answer. We don't exactly know where Dr. Nkenga Song's going to take things when he arrives. So some of this is to be continued. But what we can say is that over the past 3 years, HIV testing services have really been hyper-focused, right? Probably to the degree that we are underdiagnosing folks. So if we look at Zimbabwe as a whole, you might be reaching 90% diagnostic rates overall, but there are still gaps, and we know that there are gaps in geographies, and that we know from Nicole and others' presentations that there are gaps in populations. So we still need to speak to those gaps as best as we can, and with as much data as we know. And in some ways, a lot of the testing that is happening isn't going to change very much, right? The diagnostic testing that's happening within clinical settings is going to continue because that needs to continue. It's diagnostic, right? That's not going to change very much. We might be able to scale back some of the screening that's happening. That's a question. The index testing is going to continue to happen because that has to happen. The integration of testing into KP services is going to happen. So once you start slicing away at this, you start realizing actually the core testing program that exists, a lot of it isn't going to change very much when we move from 89 to 91% diagnosed, or 94 to 96% diagnosed. There's not some magic switch where everything's going to change. I think there is a discussion around sort of investment in diagnostics, in sort of broader community-based efforts, in how geographically we're targeting, or how we're sort of shifting things to target those populations that aren't yet, or have greater gaps, right? And might not be meeting those global targets. So there's a lot of discussion happening here. It's not a space that's really been reified yet in terms of like, this is what we're doing, this is the direction, but I think there's opportunity to think through into COP22. And then we had a question on from Broxidius on the shortage of rapid test kits. Can we use self-test kits for HTS-TST? There's not a simple answer to that. And the reason there's not a simple answer to that is because globally, there had been a decision made from WHO, UNAIDS, PEPFAR to say self-testing, given it's a screening test, given the limitations of the general population untrained performing that test, we are not going to assume that a reactive test is a positive test that's then integrated into an algorithm. So we separated out those things. And in separating out those things, we separated out the indicators. And we said, well, self-testing is not part of TST. It's a different thing. And so we're going to take that and measure that as a different thing. And it's not really related to a diagnostic algorithm that is telling you that you are HIV infected. We are accepting that self-test will tell you, and there are limitations to this, that you are HIV uninfected. If you're negative, we are making an assumption that you are negative, but there's problems with that piece as well, because self-tests aren't perfect, they're a screening assay. So the short answer to your question is no, at the moment. The longer answer is that may change, right? Self-testing, if you think of it as an A0 or as a screening test, might have some function in the level of testing or retesting that's happening in a clinical setting when that testing is confirmed, because you're actually having a high prevalence population, those self-testing positive, moving into a testing scenario. And so the positive predictive value of that downstream testing is going to be really high. So I'll stop there. I think I got to 2 questions and turn it back to Lindsay. Thank you. Over.
Thank you, Vincent. I think we'll pass it back over to Nicole on a question we're getting for any specific strategies on how to integrate existing care and treatment programs with OVC. Over to you, Nicole.
Great. Thank you, Dr. Kasambala. That's a really great question. And I think where we've seen this happening and be most successful is really at the partner and the health facility level. I think in Tanzania now you call them councils, but I think you would need to, if you don't already have an existing relationship or know the OVC partner in the specific, SNUs or councils where you work, I think that is the first place to start. We've seen a lot of great collaboration. We've encouraged, and many partners have MOUs in place. So there's explicit description of how the clinical and the OVC partner are going to collaborate and share information and share data for the benefit of the beneficiaries, children and adolescents. And I would just also make a plug for our panel tomorrow. We do have a session tomorrow where we'll hear from local partners, and it's called Local Partners Going the Last Mile to Close the Gaps in Pediatric Treatment. And Dr. Carol Tate will talk about her experience in South Africa. She is from Inova. So hopefully you can join that session and hear more, and happy to respond to you offline if you have any other questions. Thanks. Lindsay, back to you.
Great. Thank you very much, Nicole. I see Patrick is responding to questions in the chat. So Patrick, I don't know if you want to audibly respond to any of the lengthy responses you've put in so far.
Yeah, no, thanks so much, Lindsay, and thanks so much for these great questions. As I wrote in the chat, we do have this is one of the reasons I've focused on the WHO package, because in the context of criminalization, the WHO UNAIDS normative guidance is an important public health approach for making sure we can get KP programs in place and have a real emphasis on the public health benefits of working with KP. But yeah, there are a few other approaches that are more direct. The Key Populations Investment Fund, which ended, gave us some strong evidence for, in certain places, focusing on structural interventions. Democracy, Rights, and Governance group within USAID in previous years, and in this current year as well, has supported specifically addressing social barriers related to LGBTQI+ rights and other elements addressing criminalization in some countries. And in some cases that can dovetail quite nicely with PEPFAR programming. And as I mentioned in my presentation, the White House memo on LGBTQI+ rights offers another opportunity. We're looking ahead to COP22, where we're hopeful that PEPFAR programming will include resources to allow programs to focus on human rights and structural interventions. So we recognize, it's been chronically underfunded for years in PEPFAR, but we do have opportunities here and there. Again, KPIF, the Key Populations Investment Fund, did provide some support for policy advocacy to address these sorts of policy barriers for addressing criminalization. And yeah, we're anticipating that we may see some more funding opportunities coming up in COP22. And yeah, as I noted in my chat, please feel free to reach out to me if you have specific questions around KP Cascades. I apologize, just in terms of what we tried to accomplish for the presentation today, I did not include KP Cascades, which is definitely an omission, because year by year we're seeing much more comprehensive data being reported for KP across cascades in every single PEPFAR program. So those cascades are available. They are required to be reported, quarterly for the port presentations, and then annually for the COP cycle. So it is an important component for really understanding, as was received by the questionnaire, that there are gaps in service across the cascade, and viral load coverage being an important area that we're trying to improve, and also the use of electronic tracking systems, including the DHIS2 e-tracker, being another way to more comprehensively track KP and make sure we have these unique identifiers, and a variety of other approaches to strengthen SI. So I believe that hopefully addressed some of the main questions, but again, I'm happy to respond to more questions. I believe my email, I think, is in the slides, but if not, we can figure out a way for to make sure our contact information at OHA for the KP team is available, so we can try to put you in touch at a country level with resources. Yeah, thanks again so much for those questions.
Great, thank you, Patrick. We still have some time for, excuse me, a few more questions. So again, if you would like to ask one, feel free to raise your hand or type a question in the chat box. We have about 12 minutes left and want to make sure we use all of the time that is necessary to get all of your questions answered. Okay, maybe we'll do one last call for questions. Okay, we did put everyone's email address on the slides. So maybe actually I'll ask before we hang up for the presenters to just type their email address in quickly into the chat box. So if people want to send any questions before the meeting is over, that might be the best way to handle that. But thank you, Tashina. I want to thank everyone for your participation today and for all of the questions that we've received. Again, this was asked for by our local partners, so I hope this was very, very helpful. Another plug for the COP guidance that will be coming out sometime next week. So please review for your specific technical sections and provide questions or comments to the Office of the Global AIDS Coordinator, because as I said, they do read and review the responses that we get from all of our stakeholders, including our partners, civil society, and government stakeholders. Thank you very, very much to everyone. We will have a break now. And we'll regroup at 9:45 here on the East Coast. So I believe that will be 3:45 Central Africa time. So thanks again, everyone, and have a great rest of the conference. Take care.